The following presentation is intended to help St. Peter and Paul Parish Extraordinary Ministers of Holy Communion recognize and report spiritual distress in their ministry to the homebound or in the hospital setting. As an Extraordinary Minister of Holy Communion, you may encounter residents or patients who share aspects of their spirituality with you. They may reveal some of their life story and give you insight into their faith as they attempt to make meaning of that story. Their words and body language may provide indicators regarding the status of their spiritual health. Spiritual integrity or well-being is a basic human need. It provides life with meaning. It can be described as a harmonious interconnectedness with the deity, the community, the environment, and the self. As we will discuss shortly, the development of this integrity is dynamic and progresses throughout the life cycle. Spirituality is essential to a healthy life. It can promote acceptance of the past, contribute to the enjoyment of the present, and provide hope for the future. It increases one's understanding of the meaning of life and provides a sense of purpose. It helps people adapt to changes, such as the shift from home to a hospital or long-term care facility. Spirituality helps people cope with multiple losses and grief. It helps during stressful life events, provides relief from anxiety, comfort during times of loneliness, and helps in preparing for death. Spiritual distress may be defined as the impaired ability to experience and integrate meaning and purpose in life through connectedness. It is the kind of suffering that develops when a person's meaning in life or previously held worldview is disintegrating. Spiritual distress can range in severity from a slight modification in previously held beliefs to what St. John of the Cross called the dark night of the soul. From a healthcare perspective, it makes pain more painful and anxiety less bearable. It should be treated according to clinical practice guidelines. Anyone, regardless of age, may experience spiritual distress. Symptoms and care needed will depend on the individual's developmental stage. James Fowler proposed that life's crises bring with them an opportunity for faith development, which occurs in stages. If a person also experiences distress as a result of a crisis, they may need a companion to assist them on their journey. Fowler's stages are sequential, but not all individuals who reach late adulthood attain the last two stages. Human development takes place across several mutually dependent categories which are only loosely correlated to a person's chronological age. These include physiological and cognitive changes, including the health status of the individual, intrapsychic and interpersonal changes, including changes in social location and cultural expectations, as well as moral development, all of which affect faith development. The dynamics of these categories are explored in Felicity Kelcourse's anthology, Human Development and Faith. You may pause the video to look at the handout on the categories of human development. The categories have been slightly modified to better fit the healthcare literature. Let's resume our exploration of the stages of faith development and look at examples of how spiritual well-being and distress may manifest themselves throughout the life cycle. Babies' nervous systems are developing rapidly. They quickly learn to rely on a parent or parent substitute to meet their physical needs. If consistent nurture is experienced, a foundational sense of trust in their universe is developed. Babies' main concern is their own survival. If all of these categories are met, the infant trusts and the virtue of hope can emerge. Hurt, neglect, and abuse will engender mistrust. When an infant's needs do not elicit a caregiving response, attachment disorders may ensue. Distress is usually indicated by crying. Toddlers begin to walk, talk, and achieve bladder and bowel control. Their thought patterns are fluid and they have difficulty conceptualizing a supreme being. They begin to be less reliant on others. They do not have the ability to comprehend the significance of what they are doing. They develop the virtue of will as their faith develops by imitating the role models in their life. Toddlers who experience shame and doubt may not develop a sense of self-worth and may later be unable to recognize the worth of others. You may hear a frustrated toddler demand autonomy. Preschoolers develop proficiency in language and motor skills needed for elaborate play. Thought patterns remain fluid and the imagination is rich. Children learn self-control through interacting with others. A conscience is beginning to emerge and punishment is feared. God is imagined by physical characteristics such as hair color, facial features, and clothing. Confidence in one's initiative helps the child to develop the virtue of purpose. Faith develops through experiences, rituals, stories, and images. A sense of guilt will develop if a child's initiative is thwarted. Magical thinking may lead them to fear that bad things happening in their life is their fault. Newfound agility allows school children to participate in sports and creative activities. They also begin to develop logical reasoning skills. They have decreased dependency on their family and form strong bonds with their peers. They have a strong belief in the justice and reciprocity of the universe. Evidence of injustice is distressing. Their industry is rewarded with a sense of competence. At this stage, God is anthropomorphized and symbolic language is often misunderstood and is taken literally. An unchecked tendency to compare oneself to others may lead to a sense of unworthiness. Regressive behaviors or withdrawal are most often evidenced at bedtime, when they feel most vulnerable. Hormonal surges produce many physical and emotional changes as the teen attains reproductive maturity. Thoughts begin to be more logical, organized, and consistent, but egotism makes teens maintain a false sense of immunity. Adolescence is characterized by rebellion against authority and conflict about previously held values and beliefs. While developing a personal identity, peer pressure may override their sense of morality. Acquiring a strong sense of identity allows the teen to nurture the virtue of fidelity. Beliefs about God and their world begin to differ from previously imagined perceptions, and they may become spiritually disappointed. Inability to assimilate paradox may result in role confusion. A teen faced with adversity may be overwhelmed. Young adults are at optimal physical functioning. They have the ability to make appropriate judgments. They begin to engage in productive work and to assume new roles within the family. They define the right from wrong in terms of personal beliefs. Women's morality is based on caring for others while avoiding getting hurt. Young adulthood is a time of angst and struggle. Practicing intimacy develops their capacity for love. An openness to a new complexity of faith also increases the awareness of conflicts in one's belief. Lack of development in any of these categories may leave the adult feeling isolated. Physical functioning begins to decline in middle age, while cognitive abilities are retained and strengthened by experience. Changing family roles allows the circle of generativity to expand. Moral beliefs are established independently of what others think. Spirituality in the second half of life involves the ability to tolerate ambiguity and paradox, to experience emotional flexibility, and to commit to values that are more universal in nature, which increases one's capacity for caring. Failing to adapt to change and reconcile conflict may yield stagnation. Diminished physiological and cognitive functioning often concerns the older adult, though many show no decline in cognition. Reaction time, however, is usually slowed. While their interpersonal world may be shrinking, a sense of integrity is achieved by acting on one's personally defined moral principles and beliefs. The enlightened extend their compassion to the universal community of all humanity. Wisdom, inner peace, and transcendence are the fruits of this stage of faith development. Those who are unable to cope with inevitable losses may despair and feel abandoned. The hospitalized and the homebound experience multiple layers of loss which can precipitate spiritual distress. These include the loss of physical or emotional health, the loss of innocence and trust, the loss of a previously held worldview, the loss of relationships, the perceived loss of relationship with God, and sometimes even the loss of sense of self. Spiritual distress exists in several domains such as despair, dread, brokenness, helplessness, alienation, meaninglessness, guilt or shame, anger, a preoccupation with suffering, and a change or questioning of beliefs. Keep in mind that the way in which these signs are expressed varies by developmental stage and by cultural context. Patients experiencing spiritual distress struggle with their thoughts. Their concerns may be existential. They may feel abandoned by God or others. They may express their anger toward God or direct it to religious representatives. They may express a desire for a deeper relationship with God. Their belief system may be conflicted. They may have no hope for the value of life. They may express grief or loss, guilt, and may express a desire for reconciliation. They may also have an overwhelming sense of isolation. You may wish to pause the video during the following 2 slides. They are included in your handouts packet. The first one defines the general characteristics of spiritual distress, and the next one is specific to children. Children, depending on their developmental stage, have limited ability to clearly communicate their needs and feelings. You may have to rely more on body language than words. Pause the video to take a few moments to look over these examples of common behaviors exhibited by children experiencing spiritual distress. Everyone suffers, but not everyone can find meaning in it. For some, this meaninglessness brings what we call the suffering in suffering, causing them to become truly afflicted. Spiritual distress can range from mild spiritual concern to despair. People should be offered assistance regardless of the severity of their distress. Spiritual concerns may be expressed as discouragement, mild anxiety, or expressions of anticipatory grief. The person may express concern about their relationship with God and feel a sense of loss if they're unable to participate in their usual spiritual practice. Lack of control over their diet may make them concerned about their inability to fast or abstain from meat. Spiritual distress may be manifested by crying or expressed feelings of guilt. Individuals may report disturbances in their sleep patterns. Their ability to trust may be disrupted and they may feel remote from God. A challenge to their belief or value system may leave them feeling conflicted. Their level of anxiety may be moderate to severe. They may express anger toward the staff, their family, themselves, and God, and may have lost the meaning and purpose in their life. Those most afflicted, the despairing, may lose hope and their faith. They may refuse to communicate with their loved ones. They may feel that life is no longer worth living and refuse to participate in their treatment regimen. They may be severely depressed and display a flat affect. All of these forms of suffering should be reported and addressed. Patients' and residents' right to privacy must always be respected unless they are considered a danger to self or others. If someone expresses spiritual concerns or shows sign of spiritual distress or despair, this information should never be communicated by you to anyone beyond the healthcare team without the patient's consent. Ask the patient if they'd like to chaplain or to someone from the church. Then ask the patient's nurse to call the chaplain to coordinate the call. Chaplaincy interventions will be recorded in the patient's medical record. If you visit someone in a hospice or skilled nursing facility, check with the staff for the appropriate protocol. Remember, even in private homes, what someone communicates to you is confidential. You must obtain their permission to share it. When you witness signs of spiritual despair, remember that by reporting it, you will provide that person with someone who can help them work through it. Chaplains and clergy are trained to journey with people along the difficult path of doubt and transition. They will listen to the individual, hear their experience, assess their level of distress, validate and name it so as to reduce the person's sense of isolation and allow the beginning of the process of recovery. They can also identify resources for support and possible ongoing counseling. With the appropriate help and support structures, people with spiritual distress can be restored to spiritual well-being, and their faith may be deepened or even progress to a new stage. In a hospital, all distress, including spiritual distress, should be identified, documented, and treated according to clinical practice guidelines. A board-certified chaplain is trained in this practice. At the University of Arizona Medical Center, the Reverend Joe Fitzgerald is the chaplain supervisor. People confined to skilled nursing facilities, hospices, and private homes can be assisted by our deacons and priests by contacting the parish office. Of course, you all know our pastor, Father Pat Crino. This concludes our presentation. Let's review a few key concepts with some case studies. Please submit your answer by clicking on the appropriate radio button. You'll be then taken to the next case study. Provide your answer by clicking on the appropriate radio button. Don't forget to submit and upload your response. Your answers will be anonymous. Thank you for your attention, and God bless you and the people to whom you minister.